Welcome back to our afternoon panel, which is the last formal session of the day. I'm absolutely delighted to be here with a panel this afternoon to consider what the next steps along the road to improved and indeed we hope excellent survivorship care might be. I'm pleased to say we've got a diverse group of people here to offer a more in-the-round view of what the possibilities might be. So I have 2 survivors of Hodgkin lymphoma up here and 2 clinicians, each of whom work in different aspects of the field of survivorship care. And I think this breadth of experience is really important because we need to consider not only the wish list that we might have for cancer care for survivors, but also the practicalities of what actually can be offered and when, so that we can shape realistic plans for further improvement. Some of the panel you've heard from already, Michael Stubblefield and Kevin Oeffinger, and I think they need no further introduction at this stage because we understand their breadth of experience. And then we also have two panelists with lived experience of Hodgkin lymphoma. Paul Edelman has very kindly stepped up to the plate today at short notice because our other panelist is unwell and unable to be here. So thank you for that, Paul. Paul was diagnosed with stage 3B Hodgkin lymphoma back in 1988, so he's 34 years in remission. He's got 2 adult daughters, the light of his life, adopted from China, and he spends the majority of his time writing and singing. He's a passionate supporter of other survivors, and he's involved himself in this from the early days of the ASCOR lists online. He's always generous in reaching out to others, and he loves to see survivors linking up. Anastasia Forrest was diagnosed with stage 2B bulky Hodgkin lymphoma at the age of 24 in 2009, and she was treated with ABVD and had a battle with bleomycin toxicity, which left her doctors divided on whether to use consolidative radiation. Anastasia opted for proton therapy and enrolled in a research study and was the first patient to receive her treatment in all protons at the University of Florida Proton Therapy Institute. And today she works as a real estate broker, is a self-published author, happily married with 2 daughters ages 7 and 9, and is passionate about Hodgkin's advocacy. She's already made significant contributions to the survivorship world, and especially to our organisation. She's created our TikTok site and populated it with some educational and inspiring posts. And as a younger survivor, we really value her voice and experience in understanding the needs of all Hodgkin survivors. So, I have a question for each of them that were pre-prepared and we've thought about. And I have an increasing stack of questions from the audience, for which thank you. And we will work through as many of them as we're able within the time that we have available to us. Michael, you're an internationally renowned specialist in cancer rehab, and you've already been instrumental, as you've told us, in developing the care for cancer survivors. What would you see as a next important and achievable step in further development of excellent care for survivors?
That's my question. That's not what we talked about.
Yes, no, it is. Oh, yes, it is.
You know, so, and she told me to be positive, so I'm going to be very positive.
And brief.
And brief,
yes.
Yeah. So the basic idea is we need more clinicians, right? I think that the way we're doing survivorship now is really only half-baked. I think the idea that Stubblefield Nasso discussed with, you know, sort of changing the payment model will absolutely be critical. The big problem in survivorship care, as somebody alluded to earlier, it's not lucrative, right? You know, it's very hard for organizations to make money just doing evaluation and management care. Like, so you make basically the same money if you're seeing a kid with an ankle sprain as a Hodgkin survivor that takes you 10 hours to do the stuff on, right? So because of those medical economics, we need to change the payment system. That will allow us to create specialists in the field that can actually really fully understand and take all of the various component parts. And I think we're moving in that direction. Like on the rehab side, I feel very confident that what we have built will continue to grow. I think for the cancer centers and the private practice oncologists, they haven't fully caught on yet that if we can get really good at survivorship, that's going to decompress them to do what they do best. And that part of the economics is also very important.
Thank
I'm done
you.
now.
Thank you.
Yeah.
No, I think that's a really good point. We need more hands on deck, don't we,
Yeah.
basically, to achieve what we want. Anybody want to say anything to add to that, or just all in agreement?
I had this thought.
Yes?
The other day I was in my car and I was listening to the radio and an advertisement came on. The advertisement was for a clinical trial that involved a drug. And they were offering compensation, monetary compensation to participants. And I guess I was just wondering just now when Michael was speaking why cancer patients who participate in clinical trials, so many of the people here whose treatments contributed to the effectiveness of modern treatments and the knowledge about treatments, how come maybe some of the funds from the money generated from the use of those drugs can't be allocated toward development of some kind of survivorship care?
Yeah. Yes, I think it's a brilliant idea. The problem is getting it, because nobody's going to do it voluntarily. Right? So I think the idea is sound, but it's really going to fall to the government to help sort of mandate that there are funds, appropriate funds, to make these services available.
That being said, our pharmaceutical companies in the last 5 to 10 years have stepped up to investing in survivorship and supportive care services, and often with reasonably large dollar grants or studies for educational or things like that. We've got a ways to go. They're making a lot of money off of the new targeted therapies, but they're definitely on their radar screen.
Great. Thank you. Kevin, with your experience of developing and improving survivorship care, what do you think the biggest barriers to getting truly excellent, universal survivorship care are, and how might we overcome them?
So, a lot of people ask why I left Sloan Kettering, and we were able to successfully, Emily, our team were able to successfully build a very large, robust survivorship program, research, clinical care, education and training. We were seeing around 18,000 patients per year for all cancer types, not just our Hodgkin or pediatric cancer survivors. But the problem is, if we had 1,000 survivors, we had 1,000 PCPs and no relationship. And there's a lot that's changing on the cancer screening side. Traditionally, we have 5 cancers we have evidence to screen for, but there's a lot of investment now looking at new blood tests as potential cancer screening. And so I was, as a primary care physician, as a family physician, I was dissatisfied with our ability to transition the long-term survivors and also what was going on in cancer screening. The Cancer Center director at Duke really bought into my vision, is that to solve the question of pediatric cancer survivors or Hodgkin lymphoma survivors, it's building relationships. And our primary care network at Duke has 400 providers across 44 clinic sites. And I have an immediate in with all of them. And we have 3 cancer treating hospitals. And I work with our oncology team. And so we do work from cancer screening or prevention, tobacco cessation, things of that nature, all the way through the handoff of a cancer diagnosis, even for the difficult diagnoses. When we say abnormal imaging, how to hand off from our primary care provider to our oncology team, or during their cancer therapy, managing their comorbidities or after therapy. So it's an experiment and process of understanding how we can build that relationship with primary care, where they won't have an hour to spend, but they'll know the right person to go to with a question. Many of you have seen your electronic health record and you see your patient portal in Epic. That's called MyChart. Epic has become kind of the standard in most larger academic centers. For providers, there's a very easy avenue for creating something we call e-communications. We used to call it e-consults. And so we've set up a system of e-communications for our primary care providers to reach out to us for specific questions about cancer survivors, cancer screening, cancer genetics, things like that, so that we can say, this patient needs a referral, or here's a 5-minute answer, and those sort of things. So I'm optimistic that there are things that can be done, not only at Duke, but could be generalized and scaled in other settings.
So improving these sort of flow of information, really, between primary, secondary care.
Larissa said it best.
Yeah.
It takes a village.
Yeah.
And what we're doing is building that village so we all know who each other is and can keep that patient and the caregivers at the center, so improving our outcomes.
And so the barriers would be insufficient means of communicating with one another, and if we can get the IT people to link us up more and put a little bit more effort into it as clinicians maybe, then we're several steps further down the road to improving things. Brilliant. Anybody else want to speak to that?
Yeah, just, the electronic, we're in Epic. And as wonderful as the concept is, the execution isn't fantastic for us yet, right? We're still spending hours going through the medical records and, waiting for AI to come to the rescue and actually tell me how much radiation you got,
Yeah.
right?
Yeah.
And exactly what the field.
Yeah.
And hey, maybe show me a picture, right?
Yes, yes. And I don't know what it's like in the States because I've never worked here, but in the NHS, the sort of IT always just seems to lag a bit behind what would be going on out there in the real commercial world, where they would be going for the best, newest solution to things.
If it was Amazon, they'd know what to do. But this
Yeah.
is,
Yeah,
they would know how to
exactly.
get me to click on the thing I left in my box.
I'll have it tomorrow, please. Yes. Thank you. Paul, you've been involved actually in supporting other survivors now for a long time. What do you think the most positive changes in survivorship care have been over these years that you've been involved in advocating?
I'm looking at them right
Yeah.
here. This is one of the most positive changes in advocating for survivor care. I had the lucky cancer. I had the lucky widowmaker in 2008. But look at me now. I'm lucky to be on the stage next to Dr. Oeffinger, Dr. Stubblefield, two superheroes that took care of me for a number of years. I'm humbled, and I was honored to be asked to be up on this stage with them. And evidently, I get to add a new description to my bio, survivor of Dr. Stubblefield for EMG testing.
Yeah, how'd that go?
I did well with it.
Thank you. Yeah, good. Glad to hear that.
When it comes to change over 34 years, and I still grapple with that, okay? Picture your grandmother learning to use a dishwasher or a microwave or the VCR, okay? Or go even further with computers and flip phones, smartphones, and video calls, FaceTime. I'm still trying to teach my mom that one, okay? I started with a listserv. Most of you know Lisa Sparks. It was a listserv. Basically, it was emails. We sent in questions, how we were feeling, and then we get a digest back with all the answers. And then I met someone named Linda Zame, who's been mentioned a lot. And I was introduced to the American Cancer Online Resource email listserv. I was told I had to go there. I was on it maybe 2 weeks before I said, I don't belong here. Because these are all survivors who are dealing with all these debilitating health issues. I don't belong here. And I would take myself off, and Linda would say, you need to come back on. I said, I don't belong here. So my anniversaries would come up. I'm healthy. Number 4, number 5, number 6, number 7. Paul, you need to stay on here. You need this. And in 2008, I learned that I needed it. And ACOR was there for me. And then a couple years later, we found Dolly, who then helped us set up LLAHL, Living Life After Hodgkin's Lymphoma. And eventually, you end up with Hodgkin's International. Okay? Now, many of you in this room have been on the receiving end of what I had unleashed on me by Linda Zame. Me gnawing on you to get to the doctor for care. I've got a tightness in my chest. I'm having a hard time getting swallowing things. And I'm there every time, and you know it, whether you like me or hate me. But I'm telling you to get to the doctor to get this stuff done. So, as far as the advances in our advocacy, we best do it when it's for ourselves. And we do it for each other. You see each other in this room, like the saying goes on the subway in New York City, see something, say something. See someone, say someone. And get them to know that. And I'm going to close my brief speech in telling you, if you have not had a colonoscopy yet and you're in this room, you should be getting one. If you're struggling with swallowing issues and really bad acid reflux, ask for an endoscopy. I'll get off my high horse.
Thank you, Paul. Thank you. And I think that's so right. You know, our biggest strength is each other, isn't it?
Yes.
And that will change things. That will, you know, we are changing the world, and we can advocate for ourselves, and we can advocate better sometimes for one another and encourage each other. And that has huge power. So never give up on that, and never underestimate it. Anastasia, you've not been out there so long as a survivor yet, but we're so pleased you're here. It's really good. And I think it's lovely because you come with a fresh take on everything, which is fantastic. What excites you most next in the next steps that you think might be going to happen in achieving more excellent care?
Thank you. I'm so happy to be here, honored to be here. I'm really excited to be a part of something. I'm excited to be a part of this here in Boston. I feel like we're making a bit of history today. And the ability for us to connect with each other is greater than perhaps ever before in history. And that's exciting. And while it shouldn't lie on the patients, the burden shouldn't lie on the patients or the survivors to seek out information and to seek out answers to the things going on that they don't understand. It is empowering. It's extremely empowering that you can do a Google search and land on Hodgkin's International and find out about a conference, and here we are. And that's honestly, I think I learned about Hodgkin's International about 6 months ago, and ever since then I've been really excited about this movement, about this purpose. So I'm really excited about people becoming more empowered to connect with each other. I am excited about the idea of this e-communication, the potential of the network. It has a lot of room to grow. My husband and I just bought a Tesla, and just to give you an example of how you can be so advanced, like they have the most advanced technology when it comes to, I think they do, with electronic vehicles, certainly very advanced. But the communication, customer service, you try to get a hold of a human being, it's been interesting, I'll just say that. And so it just goes to show how you can have such a sophisticated technology, like we have the internet, we have groups, we have forums, we have, networks with each other, we have doctors, we have, and the doctors each have their own kind of e-communication system. And it's good, it's getting better. But we have obviously a really long way to go. But I am excited, I think we're on the right track. The collecting of information, the adult survivorship long-term study that was mentioned earlier by, I think it was Shelley.
It was.
Okay, I'm excited about that.
Yeah.
Just the ability to gather information, to connect with each other, and to help, just help everyone move forward and live the best life possible.
And I think it is exciting, and there's new technology. For example, we were talking, Erin earlier on was talking about the people who don't even know that they need to know. And I think that potentially with social media and wider e-communication, we have the possibility, and I know one of your TikTok videos at least is reaching out and saying, if you know someone, tell them, and if it's you, then seek help, because that's a good way of getting the word out to people, isn't it? Which is exciting.
Yeah, absolutely.
Yeah. Great. I have got a fistful of cards here, and we have got 40 minutes. I think we can rattle through quite a lot, hopefully, amongst us. What do you reckon? Let's see. So somebody has asked, would you consider survivorship care more about management of issues rather than cure? I mean, my gut feeling for that would be, yes, I would. But may I turn that over to you, perhaps, Kevin? Survivorship. Would you consider survivorship care to be more about management of issues rather than cure? I think the clue's in the question, really, isn't it?
Yes. I mean, we used to, years ago, call a survivorship care plan even a life plan, because it's not a one-time document, much as Larissa said in her talk, it's a continual communication that requires updating as we have new evidence and things of that nature. So yes, it certainly is issues. And I think Paul even described it. There are phases after a cancer diagnosis or after completion of therapy or even with continued therapy that is different one from another. And there are time periods when there's really not a lot going on. Probably the best example of that is the Children's Oncology Group. We make recommendations for echocardiography after higher doses of doxorubicin or adriamycin. But in those first 5 to 10 years, we rarely see a whole lot unless we saw it during therapy. And it's really 20, 25, 30 years later. And so sometimes we get lulled to sleep during that time period. So thinking of it as a lifelong series of steps to keep us healthy. So it is the issues. The cure, whoever said cure in 5 years? Aaron, of course. You know, Susie. It's an easy metric that has been used for eons because early on, 5 years was a real success story. But we have, through the Childhood Cancer Survivor Study, really focused on 10, 15, 20 year, and not just cancer-specific mortality, but looking at all causes with that. And I think in oncology in general, people are moving in that direction. We certainly think of that for breast cancer, for prostate cancer, things like that. A 3-year progression-free survival or a 5-year survival is not necessarily the best metric. So if we go back to that sense of cure, I don't want just a cure of the cancer, but I want the highest quality of life 20 years later, 25 years. And I want prevention of deaths that are related to the cancer therapy as best as we can.
So it's a complex. Yeah.
And if I could add to that, as a patient of Dr. Oeffinger's, my first appointment, I'll never forget, you know, basically how he approached, because I was in bad shape. His words, I can't reverse what's happening to you, in reference to the late effects that I was dealing with. He goes, but we can help you to slow them down, and we can help you to deal with them. I didn't hear the words back then that I did just now, quality of life. And when you get involved with a survivorship clinic or a physician who understands the late effects that you're dealing with, they can help you towards that quality of life that we all deserve 30 years, 40 years, 50 years, and 60 years into survivorship.
Here. And that's referencing really what Michael was saying in his talk about people living to the best that they can within the limits of what is going on for them.
Right. It's kind of the obvious bad news for everybody. Nobody gets out alive. And I look at radiation and other late effects like getting older, right? We can't stop you from getting older, but we can make it much more tolerable, right? During the break, a number of people approached me with dropped head syndrome, which, you know, am I going to cure your, or not me, it's really, I take all the credit for what my therapists do, but, right, they come for me, but they stay for them. And the whole idea will be, we're not going to cure you, but it's rare that a new Hodgkin's or head and neck survivor comes to us and we can't make them better and keep them better for a prolonged period of time, right? But ultimately, just like getting older, things are going to start progressing. So we don't really talk about cure so much as you said, optimization, and very importantly, prevention for the cardiac and other issues, you know, saving lives that we can save by, you know, looking, right?
And kind of following on from that, somebody said that many survivors, like the writer, aren't currently connected to holistic survivor programs, so they haven't got access to that sort of in-the-round optimization support. So primary care physicians are short of time. They say, how do we get access to someone who can quarterback, that's got to be an American term, quarterback our care?
Yeah, so, right, we were having a discussion about this at lunch, right? The state of medical art right now is that physicians are seeing a lot more patients than they used to. You got 30 minutes for a new visit, 15 minutes for a follow-up. So that's your sort of average primary care physician. So that means that you have to kind of adjust and meet them where they are. So when I go to a doctor, I have all of my medical, it's just, fortunately, we just front and back one page, very clear, concise, right? They don't have to ask dates of when I had that surgery or whatever, it's all just boom right there so they can plug it in. And if you go to the doctor with 20 Hodgkin's issues, that you should understand that that first visit's gonna be about documenting, not curing all 20 of them. And then what I recommend is frequent touches, right? So can I come back in 2 weeks so we can talk about my neck pain? Then can I come back in another 2 weeks so we can talk about my shoulder pain? And sort of rolling it out within the context of what they have. I'm lucky because I'm not, you know, and I think Kevin, certainly when you were at Sloan Kettering, there's no private practice in America that can have their nurses spending 8-10 hours working up a chart, right? It's just not feasible. So you have to understand that you have to kind of help them where you are and advocate for yourself. Shouldn't be that way, it just is.
And I think speaking as, you know I'm not part of the panel, but just responding to that, I'm a physician, now retired, but I'm a physician and I'm a Hodgkin survivor. And I'm from both sides of it. I think this is all about teamwork. It's about the healthcare givers and the patient and their supporters, whoever they may be in their life, working together as a team to make it happen. So it's not a blame game, I think, at any point. It is about meeting people where they are with what they can offer you and breaking it down into bite-sized chunks, which as a patient or a survivor, I think works better. You know, I can cope with one, maybe two things at a time, but I can't cope with lots of things at a time. And I think that works for all of us. So breaking it down like that. So if you haven't got a survivorship clinic near to you and your primary care physician seems too busy, possibly you can rethink that, and your primary caregiver is not as busy as you think they are, or they are, but actually it might work really well for you to break it down, just as Michael's describing.
And I think I learned this from Kevin and the survivorship team at Sloan Kettering, because they had the most beautiful notes. And when I started off, I was writing one run-on sentence that was completely undecipherable about the issues. And what I started doing, largely based on your survivorship notes, is breaking everything down. Cardiovascular, pulmonary, renal, endocrine, neuromuscular, musculoskeletal. And under each one of those, I'd write what the major issues were, if you had your echo, whatever it is. And that allows me, and that's how I train my residents and fellows, to keep track of a very complicated patient. So that's how we did it in medicine, and you kind of step away. But that's also for you guys. Break it down by sort of body system. There's only 11 or so of them, right? And, you know, and just put down what it is. You have cardiac issues? Cardiac. You have separate from your heart, you have some vascular issues like carotid stenosis. Write that. When you have your last Doppler, what degree of stenosis? That way, when you hand it to the doctor, they're going to, be very relieved that you've made it so simple for them. And even my residents, the new ones, all I have to teach them is you have to do every system, right? You ask the patient about every system, you research every system, and then you won't forget stuff. Although clearly I'm not actually asking sexual health enough, so I'm going to do that.
Does anybody else want to respond to this? No? I hope that's helpful. Someone's asked, or commented really, that there's been a lot of discussion of childhood cancer and wondering about how that translates into those of us who were diagnosed and treated as young adults, and are the long-term effects different for the young adults than they are for the pediatric patients? I mean, it may be partly that we don't yet know the answer till the studies are done, but...
I think it's different in a couple of ways, but very similar in others. The very obvious ones are developmentally. I mentioned Linda Zame earlier being a psychoanalyst, and we always talked about the thinking that went on for somebody diagnosed between the ages of 9 and 12, pre-adolescence, early abstraction, versus 13 to 15 versus 17 to 19, the way we internalize, why did I get cancer? And more times than not, I've seen that it's a greater struggle with our thinking when we are in that pre-adolescent period versus a child, et cetera. So regardless of our age of diagnosis, whether we're 22, 32, 42, where we are developmentally, I think makes a difference. As you might imagine, physiologically, radiation and chemotherapy impact things differently based upon age. So the classic example is radiation for breast cancer. for a woman prior to the age of 30 increases the risk. Beyond the age of 30, that drops down fairly dramatically to being pretty negligible by the age of 40. Versus heart disease, doesn't care what age you are. You can be 15, you can be 45. The radiation impact to the coronary arteries or the valves is essentially the same on there. So there's some things that are different, some things that are very
similar.
Very much similar, yes.
That's really helpful, thank you. And some things we may not know the answer until more longitudinal studies are done, I guess, like the adult survivors of cancer studies that are planned. Anything to add? I'm going to pick up on what you said about breast cancer because I've had a question about male breast cancer following treatment. Are you able to speak to that?
Yes, we've studied it. And my male patients ask that. Do we see a higher risk for breast cancer following chest radiation for Hodgkin lymphoma? I've had 2 patients in my 30 years that had breast cancer following their Hodgkin's. We've looked at it in the childhood cancer survivor study where we have roughly probably close to 3,000 or so men that had some form of radiation to the chest field on there. And we've not had any cases in that situation. Every male that I see, and Paul can probably agree, as I go through the exam, I say, listen, you know, this area was irradiated. We don't see an increase in breast cancer. But if you see a change in your breast, let me know. And I do a breast exam on all of the men that I see in clinic. And so rare, but we're used to seeing lightning strike twice. So.
And somebody else had actually said, was there a recommendation for men for breast cancer screening? And I guess you've answered that, which is no, but it would be breast aware, I suppose, for men.
Exactly.
And as you need to be really with anything else, just being vigilant really and noticing and reporting changes. Great. And following on from the theme of screening really, are there recommendations? The same person actually is asking about colon cancer screening, and somebody else is saying, if your colonoscopy finds serrated polyps and they're successfully removed, when should you next be screened? And is it different from the standard of 3 years for Hodgkin survivors? So those are kind of linked with colon screening.
So our updated guidelines from the Children's Oncology Group, which I think are applicable to people diagnosed at a later age with radiation to the abdominal field, is to start screening either at age 30 or 8 years after the radiation. And that 8 years just simply reflects that there's a time period for a new solid tumor to develop due to the radiation. So we start screening with colonoscopy. Some people think that you can go with FIT testing, which is probably okay. But my preference for the first screen is for colonoscopy. The one area we're not quite sure, I mentioned in my talk, was those that were treated with high doses of procarbazine. And I've seen enough cases that I have been encouraging people to start screening early. You've seen in the general population, I serve as the previous chair for the American Cancer Society's cancer screening guideline and panel, and we released our updated colon cancer screening guidelines a couple of years ago, where we moved the age from 50 for the general population down to 45. And that's simply reflecting that we're seeing more colon cancer, more aggressive colorectal cancer in younger individuals than we saw 15 or 20 years ago. So if no radiation below the diaphragm and no high dose procarbazine, probably reasonable to start at age 45, but otherwise if you had an abdominal field. The last thing I'm going to say is it's very easy for patients to remember that they had a chest field. 100% are accurate in recording that. I have been impressed that people that had abdominal fields didn't recognize it. And one case I always think of is a highly educated, very bright woman who was treated at Stanford, thought, nope, just a mantle field, that's all. And when I got her records, she indeed had a large abdominal field with high doses. And sometimes we get kind of lost of all of those days going into the radiation treatment center, et cetera. So going back to what Michael said earlier, we, as best as we can, getting those records to know what the field was and what the dose was, and that'll help us drive our screening recommendations.
Thank you. So be aware of what treatment you had is the important lesson there, isn't it? Yeah. Do we know how are young doctors today being trained about late effects, and do we think it's adequate?
I torture my residents on a weekly basis. I'm joking, of course. So I think I can speak to the rehab field. Maybe Kevin can talk this sort of medicine. But yeah, cancer rehabilitation's becoming a sexy field to go into for residents. I think they like the idea that it's not sports medicine where you're just, doing an injection through a hole like this and never actually getting to know your patient. You're following them long term. And that has, and for those who really like medical complexity, fantastic group where you actually get to be a doctor instead of just writing for physical therapy. So I think for them, they're absolutely learning about cancer treatment and late effects. And we have at least one student here who's very interested in it, which is one case, point in sort of that concept. In terms of other clinicians, maybe Kevin can answer more. I feel like it's getting better, but it's still not where it should be.
When we were talking about primary care providers and the time that they have to spend with patients, there was a paper last year that was a repeat of a year paper from a few years back, that if a primary care provider did all of the things that are evidence-based, grade A evidence for prevention of care, that it would take them 26 hours in one day for their care. If they used a team approach that had their medical assistants and nurses and APP, advanced practice providers, helping you can get that down to 9 hours, but that did not include acute care like diabetes and things like that. The medical school curriculum is just like that. So is the nursing curriculum, so is the physician assistant. It's just jam-packed with so much because medicine is evolving very quickly. And to be able to get the things we want is often, it goes back to, I loved Larissa's video. I mean, those are the powerful things that sometimes just seeing a panel or a snippet just says, something's a little different, regardless of whether, again, it's nursing school education, physician assistants, or medical school, or our residents. So we still have a long ways to go, but I want to remind you that their curriculums are jam-packed with so many things that we're battling.
So I'm curious, though, on this question. We have a whole lot of real experts about the knowledge of medical professionals. So I wonder if anybody in the audience who's been dealing with this for 50 years, do you feel like your clinicians have, on average, gotten better over those 50 years at knowing things? I see some head shaking. Who thinks they're getting better? Who thinks they're not getting better? It's about equal.
50-50.
Interesting. Okay.
Yeah, interesting straw poll, isn't it?
Yeah.
So I guess we just all keep carrying on trying to educate our doctors whenever
Slow,
we meet
steady
them.
pressure.
Yeah, okay. Coming back to knowing what treatment you've had, what do we do if our records are not available to us? Any tips?
The best we can. I mean, the patients will often have some idea, although Kevin pointed out, it's amazing to me how little they remember. It's like this very traumatic time, and it's just, I think Aaron was saying, I remember every moment. I think other people are like having blackout during the time and barely remember anything, and we all handle it so differently. But we can usually piece it together. Often there's tattoos like this big on patients for the radiation. That gives us a clue. Who has gigantic tattoos? Yeah, sorry. That's when you let the resident do it. Never let the resident do it. Right. Then other patients have these little microscopic, it's like, you're sure that's not a mole or a freckle? Anyway, so, we can often tell, and we can often tell, at least for me, I can at least tell where the radiation was by imaging, believe it or not, because I can see leaching of the bones when we're in the field if I need to do that. And also just your symptomatology, we can usually get an idea. So we piece it together as best we can, and then plan for the worst. Like Kevin, if you don't know how much radiation somebody got to a heart, what are you going to do? You're going to screen them, kind of at high risk, I would guess.
A couple, I think that's exactly right. A couple of things is, one is radiation treatment summaries are probably the best kept medical record there is in medicine. even in community setting. So if you've gone to medical records and tried to get your records, that takes 6 months. But if you work with your provider to actually call the radiation oncology site and ask for a radiation treatment summary, it's a one-pager.
Yeah.
And I have found that we can get that 95% of the time, unless the records were burned, et cetera, even in smaller settings. So those are available, but they're not available in the way people think of. They're trying to get medical records and they get delayed, et cetera, like that. So a radiation treatment summary from the actual site that delivered the radiation. In talking with patients that had chemo, but they're not sure what type, which is very common, almost regardless of age, I first ask, did you get the red medication? And people answer that correctly. If they had adriamycin, I know that they also had bleomycin. If they didn't have adriamycin, they likely didn't have bleomycin. So I can start thinking through at least on that. And then you can look at gonadal function, ovarian function or testicular function. If you were on MOP, and what Aaron said earlier, nitrogen mustard was horrible. But even it's the next phase where we went with cyclophosphamide high doses. We can tell a lot of times whether somebody was on a MOP or a COP or a similar type protocol with that. So a couple of questions that are fishing give you a sense of getting the radiation records, the fields, the doses, and then also the chemotherapy. Nowadays, therapy is so very targeted. For Hodgkin's in the US and in Canada, there's 5 levels of risk. And so the treatments are very different, and each one of those is usually in a clinical trial where somebody's randomized to different types of therapy within that. Our radiation fields, Anastasia talking about proton.
Right.
Proton is revolutionizing things. Even with involved field or involved nodal radiation, there's a whole change in the amount of radiation to the dose and things like that. That's why we need studies that are supported by the National Cancer Institute and Emily's office on that. But getting the level of detail to the best that you can is key. And I think a few questions by the clinician a lot of times can at least get you into the ballpark that would drive us in one direction or another with our screening or a response to new symptoms.
So we draw out what we can, and actually that can be pretty useful, is what you're saying,
Yes.
I think. Yeah, even if you don't know the exact details of
And
it.
for proof, Dr. Oeffinger had to do that with me.
Yeah.
My chemotherapy records were incinerated, whereas my radiation records were available. And he was able to get that. And then he estimated based on the time when I was treated, my knowledge that I knew I got MOP ABV, and then he just did the math from there.
Great, great. Okay. I've got several here, and we're not going to get to them all. So if your question has not been called and you really want to come and talk to one of the clinicians afterwards, then hopefully they'll be happy to speak to you afterwards. I'm going to quickly say, can radiation fibrosis affect the liver, and can it mimic fatty liver?
Yeah, I think so,
Yes.
yeah.
Don't see why not.
Yes.
Yeah.
Interestingly enough, we don't see as much
Liver
fatty
toxicity.
liver in our Hodgkin survivors as we do in some other populations. Our bone marrow transplant patients, ubiquitously, almost all of our allogeneic stem cell transplant patients will have a fatty liver. But we're starting to see fatty liver in general in the country, both in the US and in the UK more frequently with that. There are reasonably good screening tests. Simply looking at triglyceride level can give you some suggestion of that. And it is important for long-term liver function.
Yeah. So that needs to be monitored if you've had abdominal radiation.
We have not,
Or is it chemo-related?
there's 3 groups of pediatric or young adult cancer patients that have had abdominal radiation, other than our total body irradiation for our stem cell transplant. Our Wilms tumor patients, and they usually have it on one side or the other. Our neuroblastoma patients that are full, those both tend to be kids that are very young, 9 months of age, 12 months of age, et cetera. And then Hodgkin lymphoma, we largely quit using para-aortic radiation or inverted Y a number of years back with that. But I've not seen a whole lot of fatty liver in our patients that had an abdominal filled with the radiation for their Hodgkin's.
Okay, thank you. Are there any research findings that connect tinnitus to long-term radiation side effects?
I don't know about research findings, but I see it. right? It's not so, how many of you lost the hair on the back of your head? Right, so your ear, and I showed you the little things we use to shield the lungs. The radiation wasn't as accurate as we'd like to, so I've seen a number of patients with hearing loss and tinnitus as a result of the radiation, but I don't know of any data on it.
The classic one we see is with cisplatin, which is our backbone for testicular cancer and ovarian cancer, but less so with our Hodgkin's. But I think what Michael showed earlier, again, bless our radiation oncologists that worked in the area in a very difficult time, but I saw two things that always surprised me. One is, if a little is good, more is better.
Right.
And I saw patients that had stage 1A disease treated with very wide, both upper and lower fields. And when our group was looking at the radiation portals, the size of the fields in some of our younger patients was amazing. And you're cutting up there to that lower jaw or higher, that I wouldn't be surprised that we do have patients that have significant tinnitus on that, or even thinking in terms of acoustic neuromas.
Seen a number of acoustic neuromas, and other cranial mononeuropathies from the radiation are very common, which is why swallowing, among other reasons, is such an issue for a number of survivors.
Okay. Thank you. And could a brain aneurysm be linked with treatment?
Probably.
A brain
An
aneurysm.
like a berry aneurysm.
Depends again on the location.
Yeah.
Okay.
We certainly see the subclavians,
Yeah.
which are main vessels here in the neck area, but much less, and we certainly see the carotid arteries on there, but higher up vessels less common.
Yeah, it would have had to, again, the radiation, because that generally wouldn't have been in the primary field, so it would have been a bit of scatter. So, and you see aneurysms without radiation, so
Yeah.
I don't know of any data
Hard to
saying
know
they're
if it's
more
linked or
common.
not. Okay, thank you. There are a couple, and I apologise if I didn't get to it, but we are running out of time, so please do come up and ask if you want to. I'm just going to ask my panel members, have you got anything extra you'd like to say at this point? Michael,
So,
anything
yeah,
to say?
I was thinking, because I thought you might ask that. But what I tell my patients is assume that it's a radiation late effect until proven otherwise. It's kind of, you sprain an ankle, just assume it's a radiation late effect. Let us prove that it's not, because I can give you a pathway to a sprained ankle, right, that involves, and if you do that, then, and you try to disprove it, I think you'll be safer.
That's a useful tip, yeah. So have a very low threshold
Very
for
low
considering
threshold.
it to be related to your treatment. Anastasia, anything you want to say?
I would just say continue to stay curious and continue to ask questions, because you'll be surprised the answers that you'll find if you keep looking.
Paul?
You have wonderful support here in this room, all over those Facebook pages and stuff like that. For those of us that are 30, 40, 50 years out, we didn't have that back in the 70s and 80s. We were on our own. Okay, embrace each other, help each other, be there for each other. Yeah, get angry at each other every now and then, but in the end, you always be there for each other.
Peer support, so important, yeah. Kevin?
So I'm going to look back at Erin. We've mentioned Linda Zame several times, and Linda and the group that followed up after she passed away, if they could have envisioned a meeting like this. And so when Erin said, would you mind? And I'm like, what do you mean, would I mind? I'm there. Do you need any travel support? Who are you kidding? I will be there. And Erin, kudos to you to pull this together. It's just such great.
I just want to say thank you to my panel. I think we've really been able to explore some of the hopefulness. We've looked back and we've come a long way. Let's never forget that. And yes, there's a way to go, but we're moving in the right direction. And I think it's really lovely to hear that from all fronts. So thank you very much, all of my panelists. Thank you.
Are we excused?
You are now excused, yes. Thank you so much.